I promise I'm going to speak less than 2 minutes this entire time, unless called upon. So, really, the goal for tonight is Dr. Lerman and I are going to go through some of the pitfalls, billing and coding questions, but we're only going to take about 15 minutes of your time with slides. We want to use the rest of that time for panel Q&A. So please feel free, type in your questions throughout, type them in at the end if they come to you later. We definitely want this to be engaging and not just the two of us talking for a half hour. Just for a little background for those who don't know, obviously Dr. Lerman's, the best laugh in podiatry and the go-to resource on billing and coding. But a little bit about SureFit and myself. I am the director of sales here at SureFit. I've been in the podiatry world for going on 15 years now, both on the supplier side, but also on the practice management side. I helped to oversee a number of clinics throughout the country in previous roles. And I've since come over in the last year or so to SureFit, which a lot of people don't realize in the podiatry world is actually a part of Hanger. So just for a little background information, Hanger Clinic, obviously the largest O&P provider in the US, going on close to 1,000 patient clinics now in every state and Puerto Rico and DC. We also are the largest distributor of bracing, prosthetics, and right up there for diabetic shoes in the country as well. SureFit is the brand we operate under within the podiatry world. We've been around a long time. We were founded by a podiatrist, and we were brought into the Hanger family in the early 2000s. But really, our goal, we work with our own clinicians within the Hanger family every day, but with external podiatry customers such as yourself every day. We want to provide best products and services, but we also want to make sure when you get paid for your work, you keep that money. And that's the pitfalls that have come up in the last 5 to 8 years, and the TPE audits. All of that has definitely made it a lot more challenging. So our goal is to both educate and provide services that will allow you to make sure you keep the money that you deserve for treating your patients and helping them get preventative foot care to avoid diabetic foot ulcers. So if you want to go to the next slide here, my last little tidbit for a while here will just be our best known service, and really what a lot of groups use us for, is our Medicare document management service. We manage the paper workflow from the point where you've done your initial assessment to getting the PCP sign off, validating that all of the paperwork and all of the documentation is correct, validating that the dates are correct, that they've been seen by an MD versus a PA or a NP, and everything in between. So a lot of our clients use our MDM service. Our MDM service is very affordable. It's $5.49 per patient, and we only bill it if we collect the paperwork and you dispense the shoes. So if we're successful, you're successful, and vice versa. We'll touch on our services a little bit more later, but I know you're not here to see an infomercial, so I'm going to turn it over to you, Jeff.
Thank you, Nick, and good evening to those who have joined this program that we are discussing, that being therapeutic shoes for people with diabetes, is super important. It's important for several reasons. I suggest the number one reason is it improves outcomes for our patients with diabetes. We have peer-reviewed literature that tells us that patients that participate in this program have a decreased rate of ulceration, decreased rate of hospitalization, decreased rate of amputation. And that's primarily why this is so important, because it benefits our patients. It allows us to better serve our patients and our communities. And if you're here, you probably know that just like every other service we provide, there are coding, compliance, and documentation considerations associated with our provision of this service. There's rules we need to know and follow. Nick just shared how his company can help us remain compliant and to help us follow the rules. I suggest it's good to know what the most common errors are, and of interest, That's actually public information. They tell us what those most common errors are. Medicare is the number one payer in the country when it comes to dealing with diabetic shoes and inserts. And Medicare payment for the service takes place from the DME, Medicare Administrative Contractors. For those that don't know, this is DME. This is a durable medical equipment thing. And shoes and inserts are paid through the DME Max. And the DME Max publish these quarterly status reports where they tell us what the most common errors were. So when they perform their reviews, they keep track of what the errors were, and then they tell us what were the most common errors. This is nice. It's good to know, I think, what the most common errors are, because the people who do what Nick and I do can provide the education and the support that's needed to help ensure if you're with us on a Thursday night watching this, you never commit any of these errors. So we clipped the top 5 here. We're going to go through the top 3 because the other percentages really fall off. And the number one error, which you can see the percentages, the number one error accounts for 19% of all errors made, deals with this documentation of medical necessity. That was one of the documents that Nick was referring to on his slide. For my portion tonight, we're going to focus in on 2 main requirements associated with this program. And this number one error deals with the documentation of medical necessity. So let's slow down and talk about what this is. This is a piece of documentation which is created by the prescribing physician, the person deciding this patient needs this service, the person prescribing it. If you're watching this, that's probably you, right? So that's, for the most part, that's us. We're the ones deciding the patient needs this. And this is not only a podiatry thing. What's about to come next, I'm going to repeat, this is not only a podiatry thing. It could be a vascular surgeon who is the prescribing physician. If the prescribing physician, MD, DO, or DPM, is not the MD or DO who is managing the diabetes, which is probably the case, then everything we're about to discuss is pertinent. If you're watching this, probably a podiatrist, but not 100%. So I'm going to repeat, physician of any kind, including podiatrist. If we are not the MD or DO who's managing the diabetes, then we have to do what follows. We must complete this determination of medical necessity where we document a complete lower extremity exam. We document the fact that the patient has one or more of those qualifying conditions, and we document that the patient needs the therapeutic shoes and inserts. But here's where a lot of people get tripped up. And we're going to go back to that list of errors. This is where the error comes in. We complete that, then this piece of documentation must go to the MD or DO who is managing the diabetes. The MD or the DO who's managing the diabetes must sign that, acknowledging their agreement, and then return it to us, the prescribing physician, and we have to maintain that in our records. I'm going to repeat, the requirement here is MD or DO who's managing the diabetes. I see a lot of errors where the person says PCP. It might be the PCP, but sometimes it's not. Sometimes it's an endocrinologist that's managing the diabetes. So be careful with that. I've seen that error made. So that's the requirement. That is one of the things that needs to get done here. That's what Nick mentioned. His service helps us to accomplish, to make sure all those boxes are checked. And that's what this number one error is speaking to, this documentation of medical necessity. And here's what it says, right? This is 19% of all failures, is that wasn't done at all, or, and here's, in my experience, what the biggest problem is, it's done, but the MD or DO who's managing the diabetes didn't sign it. And that's what the number one error is. either that wasn't done at all, or it was done and maybe it was sent to the MD or DO who's managing the diabetes, but they never signed it and returned it. And that's got to be in our records. And by us, I'm using us as the prescribing physician. If our records are checked, we must have that signed and returned from the MD or DO who's managing the diabetes. And if you're working with Nick and participating in that MDM program, you have no chance of making that mistake because the shoes aren't going until that document is complete.
And
The second,
Dr. Lerman, before
yeah,
you jump there, would I just
please.
say the most common thing I think we see too is people or offices will get a signed document back, but it's an NP or a PA. They just take it at face value, not realizing that it's on you as the prescriber to get the MD or DO signature. It's not on your referral source to make sure that the correct credentialed person signs off on it. So we get that one commonly where, you got a signature back on a piece of paper and you think you're good to go, but you didn't actually check the NPI number to confirm that was the MD or DO. So that's another common one where we see people think they got it right, but got it wrong.
It's a huge problem. And in my experience, it's becoming more of a problem because a lot of these people don't see their doctor anymore. And if we say, who's the doctor who's managing your diabetes? Oh, I see Kathy. Who's Kathy? Well, that's the NP over at Dr. Jones' office. Well, when's the last time you saw Dr. Jones? And the patient says, oh, it's been years because they love Kathy and Kathy's really, really, really good at her job and is doing fine managing the diabetes. And that may all be fantastic. It doesn't change the rule. So then that begs the question, well, can the NP or PA sign this? Nick just shared no, and that's correct. There is an exception. There is it's
The
very rare, and I could read
the
it off.
PCF, the PCF
Yeah.
demonstration model. So I know we have some of our compliance people watching on this call and they're probably tingling right now because we were really hopeful this was going to be a game changer. What we found is that so few people have enrolled in it that 98 out of 100 times when even if you have a NP or PA in an area where they could enroll, they haven't. And trying to figure out whether they have or not is actually really difficult. So within our system, you can verify NPI numbers, credentials, everything to make sure that who the patient gave you is right. But when it comes to the PCF demonstration model, typically they're not in it. And they're unless they directly tell you as a referral source they are, I would not assume that they are, even if you're in a territory where it's valid.
Nick said almost the exact same thing I was going to say, and we didn't even plan that ahead of time. And I'm even going to add more caution. Well, not more caution, but I guess a negative to it. My experience is exactly the same as Nick's. I was going to say there is an exception. I could read it to you. I don't even have it memorized because it is so extraordinarily rare that all of those boxes are checked. And then what I'm going to add to what Nick said is if you actually read all of those rules and all of the boxes are actually checked, by the time you're done, it's just as much work to chase down the MD or DO to get it signed. And when you read everything that needs to be done, really you think, well, what good is it? And same experience as Nick in the entities that I support and do work for, we had asked for that because as more and more people are seeing their NP or PA more or only, it 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 makes it would be nice if that were an option. And just like Nick, when that first came, the headline looked great, but when you read all of the fine print and the details, almost useless. There are very, very, very rare scenarios where it can help. But I'll say again, even when all those boxes are checked and you read everything, it's like, well, that's silly. By the time we're done with that, doctor could have done it anyway. That's our first question that came in. So that was actually that was good.
And there's also though what even further complicates it is when you have a party auditor, they don't always go to check if that NP or PA is in the PCF demonstration model. They just assume you didn't get the MD or DO. So even when you check all those boxes and do it right, you still might have an audit, which you will win, but it's added work and it, reduces your profitability at the practice management level.
So that number one reason dealt with that documentation of medical necessity document that we talked about. The second most common reason deals with this statement of the certifying physician. So it's really important to differentiate these two documents. These are two completely separate things that need to be completed. And now we're looking at the other one. This is the statement of the certifying physician. This one must be completed by the MD or DO who is managing the diabetes. So the other one was we, if we're the podiatrist, we can fill it out and just have them sign it. Now we're on to the statement of the certifying physician, where the MD or DO who's managing the diabetes must be the one to complete this. We can prompt them, we can give them the blanks to fill in, but they need to be the one to actually complete this. And this is where that doctor is saying, I certify that the patient has diabetes. The patient has those conditions. There are 6 of them, one or more of those 6 conditions. The patient is under my active management for diabetes, and I certify that this patient needs the diabetic shoes and inserts. And you can see that the number 2 reason for failure, the number 2 most common error, 12% of all errors that are made with this program, are that we did not have that from the certifying physician. And I'll say again, in my experience, most of the time, the prescriber, what's very likely a podiatrist, sends it, but then the pitfall is that they never get it back, or it's not completed properly, or it's completed and not signed. But the majority of the ones that I see is that they just never got it back, and the prescribing physician, the podiatrist, just goes ahead with it anyway, which is no good. That's the number 2 most common reason for failure. And number 3 is kind of a combination of both, where they're just saying that we have nothing from the certified physician. So this is the dispensing provider, very likely the podiatrist, if you're watching this, has nothing from the MD or DO that's managing the diabetes, and that's no good either. And I'll say again, I'm just sharing my experience. When I see these records, most of the time we send it, we tried, but then it never comes back. And I'll say again, that's where Nick's company can help with that. So I'll sum up. These are the 2 big documents I wanted to focus on because they speak to the top 3 reasons for failure in review from Medicare for this service. We talked about both. I won't repeat all that. Nick has a document which is very similar actually to the one that I made there, which is a summary which puts together what needs to be done, who needs to do it, and in what time frame must those be completed. So it's actually very similar messaging. It's just packaged a little differently. This is actually straight from Medicare. This is straight from the DME Max, and it's consistent with everything that we've said. And I'll transition it back to Nick to speak to this guidance and how he and his company can help us remain compliant with this.
Yeah, I'd say one of the more common questions, and we saw it come in ahead of the webinar, so thank you to those who submitted early questions, is just, reassurance on the timelines. So I wanted to put this slide up. Obviously, Sarah and Ann will publish the webinar. We can also, if you'd like the link to this with CMS, we can send it along. But it's a little crowded, but still a good visual if you're more of a visual person about the specifics on the timelines. Obviously, a big thing we see with we help manage over 10,000 diabetic shoe and insert prescriptions a year that we dispense. And with that, some of the big things we see will be, even when the notes come back, if that MD has not seen the patient, in 2 years, like Dr. Lerman's example earlier, but Kathy, the NP, saw them in February, they need to go back and see the MD. So our system both has an automated component where we're tracking critical dates for yourself, so you know when things have to be achieved and dispensed by to be within these time periods. but it's also a very manual component where we have a whole team of people who are going through the paperwork, because a lot of times we'll even get back MD notes, and they might be great notes about the patient, but they don't mention anything about the treatment of diabetes. It might be about their last flu visit or the physical they came in for their life insurance exam.
Right.
So you see some crazy stuff when you get this paperwork back, and especially Jeff, this in the audits, you know, there's a lot of aha moments of like, hey, did somebody look this over before just packaging it together? So I thought this timeline was helpful for people to see who are more visual. So my last little plug on the MDM side, and then we're going to dive in. There's a bunch of good questions in here, so thank you. So we'll answer a bunch of these live versus typed. Uh, my last plug. So our system has multiple options. If for those, I see a number of our current customers and partner physicians on here. So thank you. But for those who don't know, obviously you can just order diabetic shoes and inserts from us and do the paperwork yourself. You can use our system to generate the paperwork, track it, and manage it, but you can still have you yourself or your team manage the PCP outreach independently of us. Or our third option and our most popular option is this MDM SureFit Obtains, where we are going to help you manage all of the PCP follow-up. Our team's going to verify the paperwork for you when everything's together and we dispense the shoes and inserts and you've added in your last pieces. We're going to zip everything in a zip file so that inevitably when you do get a TPE audit, you're ready for it. And a call out I'd say is just everybody gets audits. And, for those on here, you're probably on here because the TPEs have certainly ramped up in the last 12 months. And we're seeing it on shoes and inserts, but on all DME, wound care products, everything else. As you know, when you pass audits with flying colors, they don't seem to come as frequently or as often right after it. But when you fail one pretty poorly, it's amazing how many codes you start getting document requests for. So really our goal with this program is to make sure that you're going to be as prepared and ready to win an audit as possible. And we have a full team who supports that.
Hey, Nick. Sorry, this is Sarah. I'm popping in from the black hole. You can see me, but you kind of answered this, but I just wanted to put it out there like very specifically, since we're talking about the MDM. What do you say to practices that respond, we have somebody on our staff, like we do this in-house? What's the benefit of going third party versus keeping it in-house?
Yeah, I'm guessing most people on here are doing shoes, but if you're not doing shoes, yeah, the two buckets we hear are we gave up on shoes because of the audits or because that key staff member left. And a lot of times they left during COVID. It's too much paperwork for somebody to pick back up. Or there are offices who still have those fantastic people who are doing great work, doing the documentation themselves in-house. From the physician or an owner standpoint, I think an advantage to using a service such as ours is it just gives you essentially more resources and more people who are monitoring all of this. So if that key person does leave, you're not going backwards trying to figure out what's been done, what hasn't been done, or how are you going to continue to do shoes moving forward because nobody else knows what's going on in that corner filing cabinet. That was the shoe person's for the last 20 years. We've all seen that. So I think that's one reason people use it. Even for those key staff members, we have a lot of them who are nervous about using our service because they're worried about how it would impact their job. The comment I've heard the most from those key people is that if we can automate 75% of it, and they're just having to deal with the 20 or 25% difficult PCPs that they need to help follow up with because they're not answering us, that frees them up to either see more shoe patients or do other stuff in the office. So even some of those key people who've always been the shoe person really get excited once they dive in and start using it because it's like having an expert team at their disposal that's at a fraction of the cost of having to actually hire more help or bring in a consultant.
Thanks.
Good question. On that note, I'm going to start reading out some questions here. So Dr. Lerman, I'm going to tee you up for a couple of these here. We have, does the PCP note actually have to say, I recommend diabetic shoes for this patient?
Yes. And the person who wrote that put it in quotes, so not those exact words, but pretty darn close. So 3 different documents that we're talking about here, right? The 2 on this slide, the one on your left as you look at the screen, the statement of the certifying physician, that's the one they have to do on their own. The second one being the documentation of medical necessity, the one that we fill out, send to them, they sign and send back. And then the third, the note from the MD or DO who's managing the diabetes that speaks to their active management of the diabetes. This question, I'm certain, is pertaining to the first one, the statement of the certifying physician for therapeutic shoes. The bullets that are on this slide were copied and pasted directly from the policy. So what they do need to document is they have to certify the need for therapeutic shoes and inserts. So they have to, the MD or DO who's managing the diabetes they have to write, this patient needs therapeutic shoes and inserts. This person would benefit from diabetic shoes. I certify that this patient needs diabetic shoes and inserts, something like that. So to the person that wrote this in, they wrote, I recommend diabetic shoes for this patient. I guess that's a synonym. You put it in quotes, so it doesn't have to be those exact words, but pretty darn close. So I think the way you worded it, the answer to your question is yes.
So the next question here is there a specific document recommended by the CGS carrier for a diabetic foot check exam or anything else?
No. No, the answer is no. This question is pertaining to the documentation of medical necessity requirement that we, the prescribing physician, fill out. And it says that we have to do a complete lower extremity exam. So the question is there anything, is there a specific form that needs to be filled in to satisfy that requirement? No, there is not. We all know what a complete lower extremity exam is, right? Vascular, neuro, ortho, derm. I suggest clearly documenting that in this note by using their words, right? Giving them what they're looking for. And I suggest, there's no rule that says it has to be this, but I suggest writing complete lower extremity exam, colon. And in doing so, we're giving them what they're looking for. Some who are watching may have heard me say this before, but it's very true. Auditing is checking boxes. That's all it is. And in this case, this is a good one because with this one, we've been given the answers to the test. There's no mystery here. We know exactly what needs to be there. Some stuff we do, we might hear colleagues say, how am I supposed to know? And I can't keep up with all these rules and they change all the time. That does not apply here. Doesn't apply. This hasn't changed in years. It hasn't changed in a really long time. And there's no mystery. There's no ambiguity. We might not like the policy, but it is very clear exactly what needs to be there. This is an open book test. They've told us exactly what needs to be there. So the suggestion is to give them what they're looking for. And I'll say it again, auditing is checking boxes. They show up to our office on Monday morning and say, I want to see your documentation of medical necessity because you dispensed shoes on this one last month. And if they open the note, one of the boxes they need to check is complete lower extremity exam. And in my experience, if they read the words complete lower extremity exam, and what follows is a bunch of podiatry stuff about examining a lower extremity, the box is going to be checked.
And I would throw out there as well. So CGS does publish a checklist. They don't have templates, but they have a checklist. And I've worked on a couple TPE audits with a number of groups just in the last few months. And I've seen the third-party auditors on the TPEs just go straight down the checklist of where is this, where is this, where is this. So I'm going to chat that link out. For those using our service, we don't put it out to the public, but for existing customers, we have a map that we can show you where in the notes you're doing through our system and everything, where how we connect to every checkbox. Because when you first see this 3-page list, it's a little overwhelming, and not all of it necessarily applies to you. So one of the things we've really done is tried to map that out, and that's been something our compliance and MDM team has done a great job with. But I'm gonna chat this link out for everybody just to the public checklist specific to CGS, because that might answer a few of the questions. Okay, so our next question, is it better to have the endo or the PCP sign the papers? I've always used whomever is writing the meds.
Doesn't matter. The rule is the MD or the DO who is managing the diabetes. So there's no such thing as one being better than the other, as long as it is the MD or DO who's managing the diabetes. The requirement is satisfied and the box is checked. So there's no such thing as one being better than the other. And if in your practice, in your community, if the one who's writing for the medications is always the one that's managing the diabetes, which that makes sense to me, then go with it, as long as that person is documenting that they are the doctor managing the diabetes.
Awesome. Okay. Next question I'm going to go to here. NP are able to practice in some areas independently, I believe. Often the NP may be hired by the MD/DO, and the NP manages the patient completely. So there may not be an MD/DO at all.
No, very big no. The answer is no. And for those that didn't follow that, I wanted to do that for the person that typed it in that will explain the question better. Nick and I explained there is a very rare, very intricate exception where an NP or PA who is functioning under the supervision of an MD or DO can actually sign the papers if all kinds of other things are met. And this person appropriately said, yeah, but there's some places where an NP can function independently. They don't have any supervision. There are 0 situations where that NP can serve as the certifying physician. If you see me keep looking down, I actually had this pulled up. So now I'm reading. This is actually from the policy that lists the rare situation where the NP or PA can do it. And it says, I'm reading now, this does not allow an NP who practices independently without MD or DO supervision, who is not practicing incident to a supervising MD or DO, the authority to serve as the certifying physician. So it is a very clear no, and we have a reference that tells us NPs that function independently can never be the one to sign the papers.
So yeah, in that case, unfortunately, while that might be the person managing the diabetes, in that case, they will not qualify for Medicare covered or CMS covered shoes. Next question. What about managed care insurance? What are the paradoxals?
Particulars, maybe? So the question is, what about, the person wrote, what about managed care? We could really make it non-Medicare, right? Anything other than Medicare, because everything we've listed here are the Medicare guidelines. Some non-Medicare payers do have coverage for diabetic shoes. Some do not. Let's be clear on something else. Medicare Advantage plans are not Medicare plans. The fact that the word Medicare is in there is really misleading. Those are private plans. So I'll be more clear. Some non-Part B Medicare plans have coverage, some do not, and each are allowed to have their own requirements. Each are allowed to have their own policies. Some that do copy and paste Medicare's, which makes it really easy, but some do not. This is a national broadcast. There are hundreds of third-party payers in the country. The only way to know if a non-Medicare payer covers this service is to check with that payer. That is not unique to diabetic shoes. That could be the case for anything that you're doing. Any question of, does this payer cover service X, shoes or otherwise, the only way to know is to check with that payer.
And what I'd put in there, because in a related question, it was asked, does SureFit's MDM service only work for Medicare? What about commercial plans? Our system is designed to follow the Medicare guidelines. Many of the privates do follow them, many don't. We've seen this firsthand with our own hanger clinics. There's some plans and even some deals that have been done where they require less paperwork. There's some that require more. There's some that just won't cover it. I know Humana's or United Healthcare and Humana can be a frustrating one for a lot of people in certain regions. What I would say is our system directly just covers the Medicare. What we find is we will have a lot of customers though who and a lot of our partner doctors who, if they find out that they have a private payer that is mirroring Medicare, will then do all their privates through our system as well, because it's going to be the same audit expectations. But given the sheer number of privates and advantage plans and so forth, we do not yet have a system that can account for every region, every payer. Definitely something we're working towards, but a lot of complexities there, as you can imagine, just in terms of the differences, even sometimes within the same city that's divided by a river and you have 2 states and 2 jurisdictions. It can be completely different sometimes. The next question is, will you call the primary to get info and documents? So I'll take that one. What our system does is we actually directly fax the primary to get the documents. We follow up to 7 times with the primary. As the documents come in, something that frequently happens is they'll give us 1 or 2 documents we need and miss the next one. We will keep following up through our portal, which is HIPAA secure. We will be messaging whomever's managing it from the practices side to give them updates so that they can update both the patient and or engage with the PCP directly or through the patient as well. But we will get those documents in from the PCP. They come into our system. Our team then validates that it meets all of the requirements, and at that point we release the order. The next question, this makes me sick to my stomach. I would say, yeah, shoes have a lot of paperwork. That's what I would say though, is back to your point at the beginning, Dr. Lerman. It's what's best for the patient. It's one of the more bread and butter, clear cut ways to prevent DFUs and to help diabetics. Unfortunately, yes, the paperwork's become pretty exhausting or sickening, but that's why services such as ours exist. And that's why a lot of offices are still dispensing shoes using a service such as ours, because trying to do it on your own is overwhelming, but it's a great benefit to your patient. And a common thing we hear and see from offices, just like offices who throw their hands up and say, I don't want to do routine foot care anymore. I don't want to do diabetic shoes anymore. Those patients refer a lot. They come back the most frequently with other conditions. When you turn away that patient base, they're going to find another provider who does it, and they're not going to come back to you for plantar fasciitis or for nail fungus or any of the other conditions. So it's a pretty bread and butter service that I would urge you not to shut the door on just because of the paperwork.
Agree. I want to comment on that too. It's really important. And when there's peer-reviewed literature that speaks to the tremendous outcomes and the benefits and the improvement in the care that we provide, there may be some extra steps involved, but we're also obliged to fulfill our oath and to best serve our communities. And I know it's easy to say this when we're sitting here in our homes and it's a little harder on Monday morning, but we're supposed to be doing this. What would you do if it was your loved one? And I'll add, that's why help is available. It's why we're here, making sure you know the rules and you know how to avoid errors. Like Nick said, services like his help us to remain compliant. And I'll share just in my own experience, I do this in my office, and my experience has actually been exactly what Nick said. People love this. They love it. And they are more likely, in my experience, I don't have any literature on this, but having done this for 20 years, they're the people that are participating in the program that are appropriately and compliantly getting the shoes through the office are more likely to be compliant, more likely to keep appointments, more likely to show up. Sometimes because they like getting their shoes, but who cares? If that's what keeps them coming, it keeps you fresh in their mind. They get a cut, and maybe that morning, instead of going to urgent care, we're the ones that's fresh in their mind. And just a point on advocacy, one of my roles is I provide support to APMA, and in the work that I've done with APMA, we are trying to fix some of this. The thing on the left, the statement of the certifying physician, that's actually written in statute. That one's in the Social Security Act. So sometimes we use, it would take an act of Congress as a punchline. It's actually that, fixing that, the one on the left, requires congressional action, which they can't agree on almost anything. So that's not what we're targeting at first. The one on the right is only written in an LCA, a local coverage article. So that is a much lower bar to get that fixed. So things like not having to have the MD or DO who's managing the diabetes co-sign our note, that's the ask. And I think will be interested to know, if you didn't already, and you'll understand, we have an ally there in the family practitioners. Because guess what? They don't want to do it either. It's more paperwork for them. They have told us we don't want to sign somebody else's note. We know many times they're not even looking at their feet. So they don't want to sign a note that speaks to the complete lower extremity exam that they didn't even do. So they don't want it either. So we have a really, really good ally there in the family practitioners. They don't want to do it either. So if you're interested in how can we get rid of this? How can we make it better? That's been the ask. There's been some traction. Obviously, we're not there yet. We're still asking for it. And when I say we, that's in my support of APMA. That's been the ask, to try to get rid of. That's the first step, to try to get rid of that. It's nice that we have an ally. We're working on it.
And that tees up a comment from one of our listeners tonight who said, my experience has been the primaries get angry when you keep bugging them, and that turns them off to me or from referring to me. I think you hit the nail on the head there. What I'd also throw out, though, is if you have your top 5 or top 10 referral sources, one of the best things you can do is see if you can bring in lunch to them and their staff. Do a quick lunch and learn with them and just explain to them why you need this, why their patient needs it, why it's a nuisance and the act of Congress has required this, but that this isn't you trying to be a hassle, but this is what their patients need. And if you need some materials or marketing stuff, and you're working with us, we can certainly help provide that. But I would take it as an opportunity to try to lunch and learn and network with your top referral sources. But to what you said, Dr. Lerman, yeah, it's a nuisance for everybody, but it's not your doing or their doing.
Agree. And I would add to what Nick said, it's the messaging, right? It's them understanding why this is so important. And most people, it's human nature, I'm not being critical, what's in it for me, right? Why do I have to do all this? What's in it for me? So I suggest a potential selling point to them. We could try, there's science that says our patients do better. Okay, that's good. Getting back to the what's in it for me business, more and more and more of these MDs or DOs who are managing diabetes are in accountable care organizations, managed care organizations, pay for performance situations, they don't want their people landing in the hospital. They don't want their people getting things cut off of them because that counts against them. Now you got their attention, in my experience. Doctor, if you partner with me on this, we have peer-reviewed literature that shows us that fewer of your diabetics are going to land in the hospital getting expensive MRIs and revascularization procedures and things getting cut off. And that relates in lower costs attributed to you, better quality scores attributed to you, better outcomes in your patient population, and better scoring for you in your whatever they're doing, ACO, managed care, whatever. And now we're speaking their language. And the hope there is that answering the question, the likely unspoken question that's in their mind of, what's in it for me? Why am I doing this?
Great feedback. So question came in, what shoes do we offer with our system? So we carry Anodyne, Dr. Comfort, Apex, Brooks, New Balance, SureFit, ProPay. So we carry a ton of different shoe options. Happy to send a catalog to whomever this is, or look at surefitlab.com. You will see we carry just about every brand and make out there. The next question we have is, do the PCP notes have to state specific verbiage about the 6 conditions?
Yes. Yeah, here it is again. Here's the requirements. Like I said, these are copied and pasted right out of the policy. So I think this one is speaking to the statement of the certifying physician. What does the MD or DO who's managing the diabetes need to document? Patient has diabetes. I am actively managing the diabetes. The patient needs the shoes and one or more of those 6 qualifying conditions. So yes, doctor must document this patient has, and then fill in the blank with one or more of those 6. Now we can help them with that. They're not going to know, in my experience. They're probably not going to know. They might need help. They might need a template to work off of. They might need an example to look at. That's what I send. They might need some prompting as to which of the 6 or more that the patient has. The answer to your question is yes, they must document specifically which of the 6 the patient has.
So 2 more questions here. And if anybody has any last ones to throw in, we still have a little time. So thank you to all of us who've stayed through this whole webinar so far. The next question I see is, what is the #1 change in compliance in the last 5 to 10 years that we may overlook because we've been doing this for a while and we feel like we know what we're doing, we've got this?
Well, there has been no, so the question is, what's the #1 change? There's been no change. There has been 0 changes. The rules are exactly the same. Maybe we could best answer that with what's the #1 error. It's not a change. Just going back to what we covered, this is the #1 error reported by Medicare contractors. Also, it's consistent with what I see in helping colleagues, which is the #1 error, which is sending out the forms and doing what we need to do on our end, but then moving forward without getting the forms back.
Perfect. Yeah, I'd throw in there, you hit the nail on the head. What could be perceived as a change for a lot of people is a lot, increase in audits or having that key person leave their office who always handled the shoes. We saw a lot of that post COVID with, staff members who'd been there and been that person who'd handled it forever, and the program really fell off. I think one thing that, when you think about your diabetic population, that really should be kind of like an annuity or your bread and butter patient who's coming back for various services. So one thing we help with is patient recall campaigns and identifying how to get them back in. So outside of just the MDM service, we have a lot of value added services that are complementary so that you can rebuild that practice base or that patient base. Another question came in that was, when you say 6 conditions, I've heard you have to have at least 3 of them to qualify for therapeutic shoes, i.e. diabetes with peripheral neuropathy and pre-ulcerization lesion. Is that not correct?
That is not correct. The policy lists 6 conditions and says the patient must have 1 or more. That answers your question, but now I can't resist. It is so important that we take this information and guidance from the appropriate sources. I see too many colleagues run into trouble by basing things off of I heard or so-and-so said or something that's in a chat room thing. This one, like I said, there is a public, this is public information. The policy is free, it's online. We answered your question. You need 1 or more. But I encourage you to read it yourself and to know where to go to get the answers. I'm going to tell you how to find it. Like I said, it is free. It's online. If you Google, I'm not going to read some big long URL. This is easy to write down. If you Google DME MAC, that's what we're talking about, right? Durable Medical Equipment Medicare Contractor. So DME MAC, no spaces or anything there. DME MAC, therapeutic shoes for FOR persons with diabetes. And I gave you that weird verbiage because that's the actual title of the policy. I'll say it again. DME MAC, therapeutic shoes for persons with diabetes. The number 1 hit's going to be the policy, and it's all right there. It's free, it's online, and then you can go by the rules from the source, not what somebody told you, not even the guy on the webinar said, but rather, and we gave you the answer, and you're here because you trust us, but you can get it yourself and know where to go for the actual answers straight from the source.
Next question. Is there a threshold number of claims that may trigger an audit? I'm doing less than 30 pairs a year. Is that something they're less likely to go after?
No and no. So is there a threshold number of claims that may trigger an audit? No. If I'm doing less than 30, does that make me less likely to be audited? No. Here's why. There are several reasons that audits occur. There's a such thing as a red flag audit where you are standing out, right? Like maybe you're doing 250% more than the second highest person in your community. Or there's been red flag could be a sharp increase. He did 5 last year and 5,000 this year. That could trigger an audit. Or, and this is why the answer to your second question is no, there are also roulette wheel audits where you were not a red flag in any way. They just spun the wheel and it was your turn. And I suggest that all of this says just know the rules and follow the rules. You just sat through 55 minutes of what the rules are and how to follow them. You know what needs to be there, right? So there's no such thing as, well, I'm going to fly under the radar and then I don't have to worry about all this stuff. No good, because your number could come up also. Similarly, I suggest that any burdensome guidelines or fear of audit should never impact the care that we provide. Don't let them do that to you. Don't let them scare you out of providing the care that you're trained to provide. Don't let them scare you out of underserving your patients who you've made a commitment to, and don't let them scare you out of making money for the services that you are trained to provide and that you are providing compliantly and conscientiously. The fear of an audit should only motivate us to learn the rules and follow the rules. And if you're with us on this webinar, you're one of those people who want to know the rules and follow the rules. So just make sure you got the rules down. Work with Nick and his company, I suggest, to make sure everything's, all boxes are checked, and then you don't have to worry about it, right? My goal in providing this type of education is to empower colleagues so that your attitude is, my stuff's perfect. Come read all you want. You want to show up on Monday morning, have a good time, because my stuff is rock solid. And if it is, You don't have to worry about them showing up. So I guess I went a little further than what the question has. A little pep talk, and don't let them scare you out of doing what you're trained to do.
Awesome. Okay, two more questions I'm seeing. Aren't all calluses pre-ulcerative?
Well, that's more of a clinical question. I'm a compliance guy, so I'm gonna be lame and stay away from the word all. I realize that's how you asked it, and I'm gonna be annoyingly careful in how I answer this. My training, I'm a podiatrist too. My training is that calluses, especially in patients that are diabetic, develop in areas of friction and rubbing. A callus on my healthy, uncompromised 16-year-old who's a ballerina, I might not call pre-ulcerative. I'm not worried about that turning into an ulcer on her. However, a diabetic who maybe who doesn't have perfect vascular exam, even slightly diminished, who has a callus on the medial aspect of their hallux interphalangeal joint, for example, as a result of rubbing up against the side of their shoe, is that at risk to ulcerate? Darn right it is. Darn right it is. So I know I'm being lame and I'm refusing to use the word all, but we know what calluses are pre-ulcerative and what calluses predict the development of an ulcer. And my experience tells me that the great majority of them in patients with diabetes are, in fact, pre-ulcerative. That's why they're there, right? They develop because something was rubbing where it shouldn't have been.
Awesome. The last question I'm seeing here is we've got a couple more coming in. If a practice doesn't do a diabetic shoe program because of all these headaches, how much revenue is possibly going out the door? I would say from that side, I think conservatively, and we have some stuff we can show anybody who's interested in this offline. I'd say around $40,000 in collections. If you have I would call it a very conservative standard patient base, and you're seeing 20 to you call it 20 patients or more a day, call it 4.5 days a week, like most are, even if half those days is surgery. If you have a pretty normal diabetic population, let alone a higher one, as you get a diabetic shoe program going, I mentioned this earlier, it really should be like an annuity where each year you're adding new patients, but the patients you dispensed last year are coming back. So it should be growing. So I think, it can really add up and be a profitable piece of what I would call bread and butter care within a practice. Somebody asked for a link to the document you showed in the presentation that helps with the timeline. Yes, I will put that into the general chat right now for everybody.